So welcome back to another edition of the Heart to Heart podcast. And my guest today is Dr. Adeel Khan. Dr. Adeel Khan is a regenerative sports medicine physician who works at the Human Mechanics Clinic in Toronto under Dr. Galea. So welcome to the show.
Yeah, thanks for having me.
So, really wanted to chat with you today. I know that there's a lot of people, out there that are having surgeries, and sometimes, they don't need to have those surgeries because, they can be treated medically. And, I figured that'd be, a good place to kind of start today because, again, I know there's a lot of people out there who are just getting unnecessary surgeries, so in your opinion, like which surgeries in particular do you find that people are getting that they probably don't need, and what sort of treatments are you offering for those patients?
Well, I think by far the most common issue is definitely osteoarthritis, which affects millions of Canadians. And for those that don't know, that's essentially a degenerative condition. It's classically thought of wear and tear of the joint, of the cartilage. But we know now it's not just wear and tear; it's actually due to inflammatory cytokines as well. So essentially, what's happening is there's inflammation that's causing pain and then also to eat away at the cartilage over time. And so a lot of patients, as they get more advanced arthritis, they're told that their only option is surgery, when in fact there's a lot of other options that have come out that can treat their condition just as well. And so I think the biggest issue is that there's in musculoskeletal medicine in general, there's a lot of patients who kind of fall in between this gap where they're like, they've done physiotherapy, they got a little bit better, but then, they've plateaued and then they're not bad enough for surgery, but then they're not good enough to be like functioning on a daily, they're still affecting their life or affecting them from doing other things. So they fall in this kind of in-between category. And that's actually like, I'd say the most common person. And unfortunately, they're told that their only option is surgery. And then for those type of people, what we offer them are different, injectable or minimally invasive options to treat their conditions. And I think the big thing is just education on, as you're a family doctor, so you understand, you guys have like, our training, unfortunately, there's so much you have to know, and it's such a specialized field now, like musculoskeletal medicine, especially regenerative medicine, that there's no way for a family doctor to keep up to date with all that stuff. And so they don't know, so they just refer them to an orthopedic surgeon, and the orthopedic surgeon is like, yeah, sure, we'll cut it out. And that's because the orthopedic surgeon is just like, everything looks like everything kind of looks like a nail because all they have is a hammer. And so, and again, that's not necessarily the fault of the orthopedic surgeon, that's just their training. And so unfortunately, as a patient, you have to really do your research. You have to kind of almost advocate for yourself nowadays because there's new stuff, and it's impossible for, unless you're a specialist in that specific field, it's impossible for your doctor to necessarily keep up with all the latest, trends and procedures and everything.
Interesting. Yeah, I can understand how, there's a lot of family doctors who probably just, automatically refer to a surgeon when their patient is, in pain, whether it's knee pain or hip pain or whatever it is. And then, so, say if you are, one of these people who has responded a little bit well to physio, but say you don't want to have surgery yet, like what would be sort of like the in-between options that someone like yourself may offer that patient?
Yeah, so we're fortunate because we have more options to offer them than anywhere else in Canada. And the part of the reason for that is because I work with Dr. Anthony Galea, who started the whole regenerative medicine field. So the first option, a lot, and this is, your regular doctor can do this too, is cortisone injections. But cortisone injections into joints are probably do more harm than benefit, because even one injection can potentially accelerate arthritis. And there's been a lot of research coming out recently about the deleterious effects of cortisone injections into joints. So I typically don't recommend it for joint injuries or like arthritis type of things. So then the other option after that is what's called hyaluronic acid injections. And the best way to think of that is just like it's essentially collagen. It's women like to put fillers in their face. It's that same ingredient, which is hyaluronic acid, and it's going into the joint and it lubricates it. And it also has a bit of anti-inflammatory effect, and so it can help with more what's called mechanical arthritis type of pain. And then we kind of get into the regenerative options, which is my specialty. And so there's different types of what's called platelet-rich plasma injections, or PRP for short. And so the easiest way to think about PRP is we're just taking your blood and we're spinning it in a centrifuge, and we're concentrating the platelets above normal concentration. And what that does is it increases the growth factors inside of those platelets, which get released, and that stimulates healing, as well as anti-inflammatory cytokines, which are little messengers that help to decrease inflammation. And as we talked about earlier, arthritis is an inflammatory process, so it helps to target that. And now the problem with the platelet-rich plasma or PRP injections is that there's a lot of different types, and depending on what centrifuge you're using and what manufacturer and all that stuff, it's going to change the composition of the platelets. And so it's not as simple as like, oh, I had a PRP injection and it didn't work. That's just like, that's like saying I took some drug and it didn't work. It's like, okay, well, what was the dose? What was the type of drug? How often was it done? Et cetera, et cetera. There's so much nuance to it. And so unfortunately, like there's no one in Canada and maybe one or two people in America even who are doing it properly. And like, so it's just a poorly regulated industry. And so you have a lot of people doing it, but not really doing it the proper way. And so we're the only clinic in Canada that actually has a scientist that measures our platelets. And so, for example, we have different types of PRP and what we're trying to target. So we have a regular PRP, which may work for mild to moderate arthritis. But then if we have more advanced arthritis, then we have something called cyto-rich PRP, which is a second generation one where we incubate it. And it's called cyto-rich because it's rich in those anti-inflammatory cytokines that specifically that cause pain in arthritis. So in osteoarthritis, you get, as I was talking about, those cytokines are really important. There's interleukin IL-6, and there's what's called MMP, matrix malleus proteinases, and all these pro-inflammatory messengers are basically causing pain and inflammation and degradation of the joint. And so what cyto-rich does is it targets those and kind of puts out the fire, so to speak. And so it really helps with inflammatory type of pain. But if you have bone-on-bone arthritis, then even cyto-rich may not work. But then there's another injectable option now that we're doing, where if you have something called bone edema, so meaning inflammation underneath the bone, so now your arthritis is so progressed that it's not just affecting the joint itself, it's causing inflammation underneath the bone. And so what we do for that is what's called intraosseous PRP, where we actually drill into the bone underneath and inject the PRP directly into there. And that targets the inflammation at the level of the bone and helps to get rid of the pain for up to 2 to 3 years. And then you do it again as needed. And so these are all options that can prevent the need for a knee replacement, for example, or delay the need for it. And so I've had treated, hundreds, thousands of patients who were told by surgeons that they need a knee replacement or, that they need surgery, and we're able to do the injections, one of the aboves that we talked about, and they're able to avoid it, and they're very happy and functioning and getting back to their life.
That was going to be my next question. So you already answered it. I was going to say, have you seen patients who were booked in for surgery and thought that, surgery was their only option? And
they just came to me because they were just like, oh, I heard about you from so-and-so. I just wanted to see. And then I'm like, look, you already booked in. So, I mean, I always usually tell them like, you're already going down this course, but if you want to try it, because a lot of times for surgery, they're waiting like a year or like even long. It's like with COVID now, sometimes like a year and a half is ridiculous. So they're in pain and they're suffering. And, as you know, narcotics are not a good solution. And there's really no other thing to manage your pain besides just like Tylenol or strength and stuff. And so they're like, what do I do? And so we give it a try. And I've had people cancel their knee replacement or hip replacements.
That's crazy. And so just so people are sort of listening, like I guess the kind of order, and I guess, this can switch a little bit depending upon the patient, but generally speaking, maybe try cortisone first. If cortisone doesn't work, go to the hyaluronic acid injection. If that doesn't work, then probably go to the regenerative medicine that you're talking about.
Yeah.
And then within the regenerative medicine, you have like your regular PRP, which I guess, there's not a ton of doctors training in it, but enough where, it's offered, enough, it's available for patients. And then I guess beyond that, like what you're doing, once you go beyond sort of normal PRP, then there's some specialized PRP that you guys have that, very few people have access to. And so that sort of is like the line, I guess, that you guys sort of follow. Is that right?
Yeah, exactly. And so the cyto-rich PRP we only have, but the intraosseous PRP, there's one other or two other docs in the States doing it, and it's being done in Europe by a lot of doctors there. That's actually where it started in Spain over 10 years ago.
Okay.
So there are people doing the intraosseous around the world, but in Canada, for sure, definitely we're the only people doing it. And
okay.
And yeah, and we can talk about later, but stem cells fall in there somewhere too. But the issue with stem cells, there's a lot of issues, but again, the biggest issue is regulatory. There's no regulation on it, so like the whole definition of stem cells is kind of skewed. And in US, if you do have American listeners, I would say stem cells probably fall after, somewhere after regular PRP has failed. So like
Mhm.
cyto-rich and stem cells have a similar type of like mechanism in terms of being a very strong anti-inflammatory.
Okay, interesting. So, and then also too, I know we chatted just briefly about physio. So obviously, physio is recommended in the first stage. I just
Yeah.
wanted to mention that. And then in terms of medications, and like yourself, I try to avoid using narcotics, opiates whenever possible of their addictive properties and what they can do. I always mention with opioids too that they can significantly lower your testosterone
Yeah.
levels. And I know that a lot of people listening to this want to maximize their testosterone levels. So, definitely avoid opioids. But in terms of, again, the medical management, just trying to going back to the basics before we kind of get into the regenerative medicine again, physiotherapy, and then would you just prescribe NSAIDs like short term, or do you
Yeah,
not?
like if I'm doing anti-inflammatories, I wouldn't usually do them for more than 2 3 week course. And then
Okay.
some, I mean, rarely like, something like what's called a COX-1, like Celebrex, maybe you would
Yeah.
do long term. But even then, like, there's been studies on this, like they increase your risk of heart attack and stroke, and long term they can cause kidney problems, ulcers. And um, I think I posted a thing on my Instagram a couple of weeks ago about how anti-inflammatories kill more people than car accidents on like a yearly basis.
Holy crap, that's
Yeah.
insane.
So it's not, it's a real thing,
Mm.
right? People pop Advil like it's nothing, and people don't realize Advil is actually a potent anti-inflammatory and it has side effects. So to me, I'm always on the side of Tylenol extra strength or Tylenol arthritis or acetaminophen if you basically need something chronically. But
Okay.
I wouldn't do anti-inflammatories chronically. And that's usually most of what I'm seeing with arthritis or chronic injuries or whatever. Is usually people with pain who are suffering for a long time. So if they failed physio and they failed a short course of anti-inflammatories, usually the short course of anti-inflammatories is just to calm things down a bit. And if it does calm things down, that's great. And if it doesn't, then we got to talk about medically management with Tylenol possibly, and then cannabis, as you know, sometimes that can work too for managing pain. And then if that's still not doing it adequately, then that's usually where we go in to talk about the injections.
Okay. And then also too, I wanted to ask you about the cartilage of a joint. So from my understanding, there's a glucosamine and chondroitin sort of like complex that's part of the joint, and sometimes that's part of the reason why people do use that as a over-the-counter supplement and get some relief. And I and then also too, and you can correct me on this, but in terms of the collagen in the joint, I know that a lot of people are purchase type 1 and type 3 collagen, but from my understanding it's mostly type 2 collagen that's in the joint. Do you have any comment on how the joint's made up, and any natural factors or things that we can do
Yeah, no,
to
it's exactly what you
support
said.
it?
It's basically, but the biggest issue is bioavailability of the supplements. And
Okay.
so there's one called undenatured collagen type 2. So
Okay.
if you're going to take a supplement, that would be one that'd be potentially worthwhile. And then there's also collagen peptides. And then
Okay.
that comes in a powder form. And usually the studies I've seen and what I usually recommend is about 15 to 20 grams a day. And that can help with joint health and maintaining prevention of, cartilage conditions.
Okay.
So it's
Okay.
really because it's really hard to get collagen through diet unless you're eating a bunch of bone broth and like that kind of stuff. So
Yeah. Yeah.
otherwise you need to supplement.
Yeah, I've always found it difficult to get a lot of collagen I mean, I eat bone broth sometimes, but
Yeah,
it's not often. Like it's once a week maximum.
exactly. It's not like a daily thing, right? So
So the collagen is, and also too, most of the collagen you can get now is, it's fairly like tasteless. Like you can even,
yeah,
when to get 15 or 20 grams, I mean, you can almost put that in your coffee in the morning.
yeah,
One or two servings like should be enough overall for it. Um, and then coming back to just to the regenerative medicine. So once you go beyond the PRP, then you have this sort of like specialized PRP that you're describing. And I know there's not too many people in Canada, unfortunately, that offer it. But what is it exactly that you guys do in the lab or in making up the PRP that makes it different and separate from the other PRP? I know you
Well,
briefly mentioned this earlier.
yeah. Well, I think the first big thing is that we're actually measuring it, which
Okay.
is the starting point. It's like all these people are doing PRP and they have no idea what they're injecting. They just get some centrifuge from some manufacturer, and then they're just like, yeah, use our PRP kit. And the doctor themselves doesn't know much about PRP. They're just like, okay, sure. And so we're actually not relying on just third party manufacturers. Like we do have some of like the brand name ones, like there's Harvest and Angel and stuff like that, but we essentially rely on making our own. And what that means is we use our own centrifuge, and then we have our own scientists who like measures our platelets, so we know exactly what we're injecting. And the same thing with the cyto-rich injection. We know what the composition is of the platelets, but also of the like how it targets the anti-inflammatory cytokines and all that.
Okay. And then how much of a level up or a difference is there between regular PRP and your PRP? Because it sounds like it's significant,
Yeah,
because
for
I'm
osteoarthritis, it's huge because think about it, because there's so many people who have that those MMPs and those interleukin cytokines I was talking about that are causing their pain, and the regular PRP doesn't target that, not to the
okay.
same extent that the cyto-rich does. So it has to be the right clinical diagnosis. It has to be an inflammatory type of OA. If it's just more mechanical, like completely like bone on bone, and there's no inflammation or edema, then PRP is not going to do anything. It's just going to be a waste of money.
Okay. So it works best by reducing inflammation, and specifically it reduces inflammation through the MMPs and IL-6. So,
Yeah.
and for people listening, those would be pro-inflammatory molecules. And so, obviously what Dr. Khan is ejecting with in his PRP is something that would reduce the inflammation from those molecules. And then with the reduction in inflammation, overall you just get a reduction in pain and
Yeah.
improve in
And it
overall.
has a mild regenerative effect on increasing the volume of the cartilage, but that's not the main effect. And that's the same thing with
Okay.
stem cells, and that's why I don't like the whole word stem cell injections. People think they're going to regrow this new cartilage, but there's a very minimal regenerative effect even with stem cell injections. And
Okay.
so we can go into basically if you truly want to regrow tissue, and they're doing this in the States, is that so say if you really want to avoid knee replacement and you're just like, I don't want metal in my body, I don't care, but you're not a candidate for PRP or whatever. We tried all the PRPs and it doesn't work. So I do have like a few people who fall into his category. And the next option is actually using what's called 3D bioprinters. And so they use a 3D bioprinter and they use what's called hydrogel polymers, and they print a scaffold of like the actual joint, and then they seed it with the stem cells, and then it actually regrows the cartilage. So yeah,
That's
so I see your, it's just like, yeah, it's crazy. It's amazing. So they've actually done this. They're actually doing clinical trials, and they've actually successfully done it in Washington State specifically. So it's a really exciting area, and that's the future of regenerative medicine, is regrowing organ, because now we know the joints are just like any other organ, right? And so that's regenerative medicine. They're going to be eventually, you can use what's called induced pluripotent stem cells and scaffolds, and you can what are called acellular scaffolds, and you can actually regrow like kidneys or regrow a knee basically. And so that's where medicine is kind of heading. So
and
instead of just cutting stuff out and just being like, oh, let's just take this out of you, because medicine, that's what surgery was, right? It's just like, let's just cut
yeah,
it out. Whenever something's wrong, let's just cut it out. It's like,
cut it out.
but instead of
Absolutely.
why can't we actually like heal it or regrow
General
it?
surgeons love taking out body parts, that's for
Yeah,
sure.
yeah, exactly. So now that's really the future of medicine. So it's exciting to have that the 3D bioprinter hydrogel thing.
And so that printer, it actually prints part of the joint. Is that right?
It's using a model to create a scaffold. Yes, based off the 3D model of the joint. Yeah.
Okay, that's crazy. And then one thing too, I want to ask you about. So, like, what would be the indication for stem cells over, say, the specialized PRP that you do? Like, when
Well,
would you
yeah, and
use
that's the
them?
thing, right? So in Canada, we're not allowed to do stem cell injections, so we don't even
Okay,
have that option. So if you happen to be in the States, I think honestly the stem cell injections are just a more expensive way of getting the same thing. So basically they're probably like double the price, if not 3 times the price. And you're essentially getting the same thing, which is a very strong anti-inflammatory injection. And that's what Cyto-Rich is. And that's how bone marrow derived stem cells and adipose derived stem cells, which are from your fat or bone marrow, but that's how they both work too. Because they don't have a very, so this is what I was so we'll talk about it now. So basically stem cells, the right word for it is actually not stem cells. The right word is actually medicinal signaling cells. So the guy, his name Dr. Arnold Kaplan, and he coined the term MSCs in 1992. And so he wrote a paper in New England Journal of Medicine 3 years or 4 years ago saying that we should rename it to medicinal signaling cell. So MSCs, instead of being mesenchymal stem cells, it should be medicinal signaling cells, because the way they work is what's called paracrine secretion. So it's all about self-signaling, and it's about what's called a secretome, which is all these different molecules and all these different cytokines that we keep talking about that change the milieu of like the space. So for example, if you do a stem cell injection into your joint, it's not that those stem cells are going to regrow a bunch of new tissue in your cartilage. What they do is they send signals to your own body to reduce inflammation and to your own cartilage's stem cells, because your own cartilage has stem cells in them, and those stem cells start regenerating. So it does have a little bit of increase in volume, but it's not because of what you inject. It's not the stem cells themselves per se, it's the signaling that they send.
Okay, so when you inject stem cells, basically what happens is you're sending a signal that's going to decrease inflammation, and then you're also going to be sending a signal to the joint that has existing stem cells to regenerate. But the stem cells itself aren't exactly regenerating the
No, it's
cartilage.
not. It's not engraftment. So
Okay.
people think engraftment. I'm going to inject these stem cells, and they're going to go in there and they're going to regrow new tissue. No, it's paracrine secretion, which is signaling.
Okay. Okay. Very interesting. I think that that helps a lot of people. Just still on the topic of stem cells though. So some people do use IV stem cells. And I know this is like a very, very, very poor source, but
Yeah.
I heard that Dan Bilzerian anyway, when he was on Rogan a few years ago, he mentioned that like when he took IV stem cells, like the next day or the next week or something, he was like 20% stronger. Like, is he just completely full of shit, or like what benefits do people get from IV stem cells?
I mean, or maybe it's just a very strong placebo effect. But
Yeah.
regardless, if even if it like IV stem cells can also have an anti-inflammatory effect, so maybe it just decreased inflammation and you felt stronger for like temporarily. But the big issue with IV stem cells and the big issue with stem cell injections in general is that we don't know what the potential risks are. And there have been studies showing, for example, stem cell injections done to spine. There's been case reports of people growing like tumors, and
Oh,
then
okay.
there's been reports of people losing their vision because of stem cell injections in the eye, because the injection that they did, it didn't turn like the tissue ended up being like, it ended up turning into what they thought, like actually ended up turning into bone. So like there's all this weird stuff that we don't completely understand about stem cells. And so there's still a lot of research to be done. And then IV stem cells is just a whole other thing where it's just like, we're going to put through your whole body. And then somehow magically they'll know where to go and they'll know what to do. Like it doesn't work like that. So
Okay.
it's completely not based in science. And any of the top regenerative guys just kind of laugh at that stuff. And, it's just a shame because Joe Rogan has a big influence. And I get to ask that question on every podcast I go on.
Oh, really? Okay. Because yeah, when I met him in person, I mean, that's what he mentioned to me, that he was getting stem cells in his knee, I think. But I
Yeah, I gotta go. I've been meaning to go on his podcast. It's one of my patients anyway, so I'll fix him up.
That's awesome. That's
Okay.
awesome. Yeah. Well, good to clear that up, because I know that a lot of people they think that stem cells are superior to PRP,
Yeah,
just because in some ways,
exactly.
maybe just because it's like less accessible and it's kind of just sounds sexier overall, but like
Yeah,
PRP, it sounds like from someone like yourself and from other the very few people who do what you do, it sounds like you guys all believe in PRP more so than stem cells, or at least has more applications overall.
it
Is
definitely
that
has more applications and definitely has more research, and so that I think that's the biggest, and has a bigger safety profile. So, to me, it doesn't make sense to jump straight to stem cells. Like, yeah, I think if you've tried all the PRPs and they didn't work, then it's reasonable to try that as the next step. But a lot of people, it's just like you said, it's marketing and hype. They're just like, oh yeah, stem cell, because it's just
yeah?
like that kind of sexiness and like of the marketing. They've done a good job with that.
Yeah, I think so. I think they got me a little bit.
Yeah.
Um, so also too, I wanted to ask you because I know that you lift weights, and are you like a kind of a bodybuilder yourself as
I
well?
do natural, yeah, natural bodybuilding and powerlifting. Yeah.
Okay, awesome. So, like, what tips would you give out there for people to maybe avoid some of these surgeries in the future, or to make sure that they're not losing all their cartilage? And before you answer that, I'll just say that I lift quite a bit myself. I don't do powerlifting or anything. My main sport is MMA, so I just kind of lift for that. But I do deadlifts and squats and bench and all that. But I was going to say for myself, one thing I think that's really helped me is I know you can't because you're a power lifter, so you have to use a conventional bar, but I use a trap bar for my deadlifts. And I know that for me, it really takes a lot of pressure off my back. And I know you're using some different muscles and you certainly don't get all the benefits that you would get from a conventional deadlift. But I find that to be something that reduces injury overall. And then the other thing I was going to say is now I use a Swiss bar instead of a conventional Olympic bar when I do bench press. And I just find between those two things, I think they've helped save my low back and save my shoulders. But being a power lifter, what advice would you give to people out there who are listening and lifting heavy weights and don't want to have surgery in the future?
Yeah, I think first of all, powerlifting is an extreme sport, so is bodybuilding. So so I don't think they necessarily have to follow what I do in terms of that. But so my advice for the general person and in general, like yeah, I think is finding leverages that work for your body is what it's all about. And so that takes experimentation, but also having a good, honestly, having a good coach or a good trainer who can give you an eye and tell you, that based off your leverages, you should be doing trap bar instead of the regular bar, or you should be doing sumo deadlifts instead of wide close grip deadlift. So and there's so much of that nuance, and I think you just need an experienced eye with that. And unless you're really into training yourself and you've learned that stuff, you're not going to know. There's just so much to know. I've been studying training for like 14, 15 years because I was a personal trainer before, and like I'm still learning new stuff, and like it's it's actually quite complicated. And so I think having an expert like a trainer is probably the biggest thing. And in terms of general prevention of like wear and tear and musculoskeletal injuries, there's such a big gap in the medical world in terms of like, and I was like, you go to your family doctor and they're going to measure, they're going to do tests for your kidney, your liver, your hormones. They're going to check out your heart, to do all this different testing, right? But there's nothing done for your musculoskeletal system. And so your MSK system is actually so important for so many different things. It's not just like it's not just what we thought before, where it's like a dumb organ system that just kind of helps with movement and protects you and looks good and this and that. Muscle is actually a very complex organ, and it all comes back to what we were talking about earlier about cytokines. So they're actually called myokines. So myokines are little messengers, and they turn off certain genes and they turn on certain genes. So there's something called oncogenes, and they actually change the expression of those. So it helps to decrease your risk of cancer. Not to mention all the stuff in terms of protecting you from metabolic disease and sarcopenia, which is like muscle wasting. And there's I think people know there's so many different benefits of it, but we understand more so why there's so many benefits now is because of the myokines. And so
And would
what I
that also be why? Sorry, I didn't mean to interrupt, but would that also be why a lot of people who have muscle wasting when they're older, like those are the people who tend to die early, are people
yeah,
who have muscle wasting, right?
yeah,
Whereas the
exactly.
people who
Grip
keep
strength is one of the best predictors of longevity and dying earlier.
grip strength.
Grip
Okay.
strength, yeah, and that's just one proxy. So imagine like if we could actually measure true muscle mass and strength and all that. So
Um, that's I didn't know all that though about some of the things that you were talking about with regards to like within the muscle tissue itself. So there's like some protective factors that it would be helpful if you had a lot of lean body mass as opposed to fat mass. So there's some protective
yeah,
factors you said in there.
yeah, exactly, yeah. So no, so really, the myokines are really cool molecules, and in terms of preventing actual musculoskeletal injuries, I think the biggest thing is getting some sort of movement assessment. Now, the problem is with movement assessments is that there's only really one somewhat validated tool, which is called a functional movement screen, FMS.
Okay,
And
I've done that before. Yeah.
yeah, you've done it before. Yeah. So yeah, basically, yeah, they got you to like, hold a bar like this or do a squat and like do a few different movements and watch you basically to pick up where there might be imbalances and then make recommendations before they become real issues. And so that's the biggest thing. It's about prevention. And so that's actually what I'm actually working on a scalable technology. I'm a co-founder of this company called Exalt. And what we're doing is we're using AI camera technology that has parts of FMS, but other components that we're developed ourselves as well to basically do movement screens. And it's just a 15-minute assessment and workout with the trainer. And we're trying to make it more accessible to the masses because we're making it a fraction of the cost of normally what you have to pay for a trainer. But I think that's the whole thing. Like there's just such a big need for some sort of primary or preventative care model for musculoskeletal conditions. Because right now you don't go to the physio until something hurts, right? And then
Yeah, no, no, exactly. I think what you guys are doing is brilliant because, like you have coaches for everything else. If you play hockey, you play soccer, you do boxing, MMA, everyone has a coach or multiple coaches.
exactly.
But, most people, now some people do, but most people who go to the gym don't have a coach or don't have someone who, showed them how to lift weights. And even though obviously, both of us are huge advocates for exercise and lifting weights, we're also huge advocates for doing it, properly and to make sure that you don't mess up your body. And in order to do that, you should get, proper coaching from someone. So, I'm happy to hear that you guys, have produced some type of app or program that can help people, maybe, navigate through that, without a trainer and for less money so that they don't encounter these types of injuries.
Yeah, exactly. It's all about the biggest thing I talk about is accessibility, right? So everyone has access to, at least in Ontario or Canada, they're supposed to have access to a family doctor, which they don't. But for the most part, that's one of the big things. But I always talk about, for me, it's like in my belief is that everyone should have accessibility to a high quality trainer or fitness as well, because that's at the end of the day what's important for good health. And we know 80% of chronic diseases are preventable through lifestyle, right? So I think that's why I kind of came up with the whole idea, and it's been really exciting. And we've had a good team of engineers and all these other people. So it'll be exciting. It'll be we finally launched, and it should be fun. Yeah.
Well, I'm super, curious about it. So I just want to ask you about like what does it? Have you guys developed it yet? Like, can
Yeah, yeah,
someone?
we have. So we just launched. So we have our own internal certification that we develop with like world experts in terms of making sure that every trainer is standardized in a high level. Because if you think about it, trainers should be like a regulated health profession, right? Just
I
like
agree. I
in,
agree.
in, in Australia, they've already done that, but in Canada and US, we're so far behind. And so what we've done is we made our own term certification. So it's really in terms of like you get so many different facets of knowledge, giving you a foundation in science-based fitness. And then we have even components of like behavior change incorporated into there. And then we have a dashboard that the trainers are going to be using every time they train clients on there. And that dashboard keeps track of data. And there's different types of biometrics and whatnot we're using, like HRV. There's one called CRF, which is cardiorespiratory fitness.
I
And then
like HRV a lot. We can talk about that in a sec, but
yeah, and
please go
so,
on.
so
Yeah.
we got Jay Wiles. I don't know if you know Jay Wiles. He's on Ben Green. He co-hosts Ben Greenfield's podcast, and
Okay,
so
I know Ben Greenfield, but I
so
don't.
yeah, he
I mean, I
developed
might know him to see him, but I don't know off the top of my
yeah, so he
head.
developed our HRV module. And so
Okay.
anyway, so the point of the whole thing is the data component of it that we're going to be tracking on the dashboard over time. So not just the movement aspect, but their health data as well. And so that's going to allow us to eventually, hopefully, better predict health outcomes. And a lot of our clients are corporate clients to say they've increased their productivity since they started using Zoll or whatever. You know what I mean? So there's two main markets that we're targeting. One is corporate clients, and the other are doctors. So the doctor can be like, because right now, if you're a doctor and your patient goes to you, you're like, I want to go exercise. What do you send them? Good Life, and you hope that they get a good workout in. Like,
Something like that. I talk to them, they sometimes they ask me specific questions. Like when I ask my patients, like, do you exercise? I often, say, like, what are you doing exactly,
yeah,
and also too, you have to have, realistic expectations. For some people, getting out and going for a walk every day is
exactly.
a big
The
step for
average
them.
person doesn't need to sweat and beat themselves up for an hour. That doesn't work. And it's a broken model that the fitness industry has like perpetuated for years. And so what we've done is we've created there's this 15-minute sessions, and you can do that as little as once or twice a week, but it's realistic for most people to stick to 15-minute sessions, and most people can make time either during their lunch break or throughout the day, right? And so we're much more about sustainability and like long-term behavior change as opposed to just short-term, diet hard, work out hard, and then just stop and go back and gain your weight again.
Yeah,
So
no, that's I can see how that would work too, just because it reminds me of the Headspace app. And for people not listening, it's a
yeah,
meditation app, but they have it so you can do it like really short. Like, I usually use it for 10 minutes, which again isn't very long. Like some people use it for sometimes use it for 20, but it's mostly 10. But you can use it for as little as like 3 minutes or 5 minutes.
yeah,
And like as long as you keep the habit up, then you're not going to be getting out of your routine. And I think that's what's like most important, whether it's meditation, whether it's exercise, like, the days that you don't want to do it, like at least do something so that you keep that momentum going. Because if you lose the momentum, it's really hard to kind of gain it back. And you can keep the momentum if you just do just a little bit. So, I like the fact that you guys are limiting it to or have, the option of doing just 15 minutes, because it gives people the option of, well, at least I did 15 minutes today and I kept up the momentum. Like maybe it wasn't, 45 minutes or 60 minutes, but the momentum's there.
yeah. And the funny part is there's actually a huge study done with like something like 40,000 people looking at, and 11 minutes of exercise was enough to improve longevity. This was like a
That's
study that they looked
crazy.
at. They followed them for like 30 years, and like they did a retrospective like analysis and stuff. And so all you really need is like yeah, minimum effective dose, right? Is like
Yeah.
11 minutes. So
And I think too, like, I know that Tim Ferriss one time talked about, I just brought him up because you said minimal effective dose. That's where I heard that term first anyway.
he's all
But
about
he was talking about like on his rower, like he does almost nothing. It's like maybe it's a couple thousand. It's not very many meters that you have to do in order to get your BDNF up. So your brain drive naturopathic factor for people listening. And that can really spark neurogenesis and just kind of, change your mood and make you feel good. So, again, it's another, I guess, the point I'm trying to make is that you don't necessarily have to do like a crazy hard workout to get a lot of the benefits from exercise.
Yeah, and that's unfortunately Peloton and Apple Fitness, F45, all the things that are popular nowadays, they all kind of perpetuate this idea of high intensity exercise. And the irony is, as a sports doctor, I see so many people get injured from that stuff, and it keeps me busy.
Yeah.
But I'm honestly all about prevention, and like I don't want these people to get hurt, and so that's where I saw this like solution for this problem, right? It's like what can they do on a primary care level to actually prevent this from happening? And so even if you do that stuff, our platform Exalt can still be complementary to it. Because at the end of the day, these people are not doing routine mobility or movement assessments, and at least now they have the option or somewhere to go for that type of stuff. And we got like Andy O'Brien, who's Sidney Crosby's trainer, and a few other
That's awesome. Yeah.
top people who developed this. So we got a good team.
That's awesome. Yeah, I met Andy once or twice before a long time ago,
Oh,
but
did you? Oh, so yes.
yeah. But I know like Crosby really credits him for really helping him out
Yeah,
and building his lower body and helping him
exactly.
with the skating and everything. One thing I wanted to ask you about too. I know you have a lot of experience with hormones, and one thing and one in particular, that a lot of people use, and again, maybe they're using it incorrectly, or maybe there's a lot of misinformation out there, but human growth hormone, like on the street, if you talk to someone, they'll be like, oh yeah, I want some HGH because I heard that it just heals everything, kind of thing. So like, what are your thoughts on human growth hormone, and does it have a place in regenerative medicine, or is it kind of overhyped?
It definitely does have a place in regenerative medicine, and even Tony, who's a pioneer of it, was using it with PRP at one point. But then there's some regulatory issues with that. There's still a doctor in the States, Dr. William Seeds. He's an orthopedic surgeon who uses PRP and certain peptides with PRP. So, and that's where, and based off, I'm not an expert in this, but I rely on him, Dr. William Seeds, who is the world's expert on it, and I've spoken with him and I've listened to a few of his things, and the new kind of shift is that peptides are actually better than the actual growth hormone itself. because there's
Oh,
different types of peptides that can target specific issues. So, for example, there's one called BPC 157, which is a peptide for healing and for tendon regeneration. And so that one he uses often with his injuries in addition with PRP.
and for
Um,
gut healing as well, right? That one helps.
yeah, exactly. Gut healing too.
Yeah.
Exactly. Yeah. And then there's other ones like Somorolin, which is like a growth hormone like analog, but it doesn't shut down your own production like taking GH would. It kind of works
Okay.
more synergistically with your body. So I think that's why the peptides are becoming more popular, and because they're more. I would say I guess they're more designer, and like you can make them in different ways to do more specific issues. So for example, like sometimes people want to take growth hormone to help them with sleep and energy and recovery. So there's more specific peptides that can target that. So whereas I think if you're just taking growth hormone in general, like it's very just like unrefined and just kind of like almost like a shotgun versus like a sniper.
Okay. Okay. Yeah. Okay. So like people, and actually, I learned a lot about this from Ben Greenfield. He's coming up a lot on this podcast, but he wrote something on BP 157, something like how to heal like a Wolverine, I think it was
Yeah,
called.
yeah. He's the one who
And
now I get at least once a week a patient asks me, "Have you heard about the Wolverine peptide?" And
okay.
then yeah.
And
So because people obviously because they're coming to me with injuries and pain and they want to heal themselves too. So
yeah.
I have used BPC 167 like with some of my pro athletes to help them recover faster. And anecdotally, I can tell you it does work quite well. But I wouldn't recommend it necessarily for the average person, just because it's just extra money and stuff. It's not enough research, not enough human. There hasn't really been human trials done yet. It's all animal
Okay.
studies.
And then I know that a lot of people too are combining the BP 157 with TB 500.
Yeah.
But I also know that, or last time I checked anyway, I'm not sure if this is true, and I might have actually read this on Ben's website, was that the BP 157 was not on the WADA list, meaning you could use it in competition, but TB 500 was. Do you know if they're both on the WADA list now, or?
I don't know off the top of my
Okay.
head, but
Okay.
regardless, there's ways around that. I mean, for people, I can tell you, working with a lot of the top athletes in the world, there's always ways around it when people
Yeah.
do that stuff and not get caught.
And
So
is there any truth to like combining the two, BP 157 and TB 500? Like,
I mean,
are
there's
they
no human trials on it. It's just based off
okay?
anecdote. And so, yes, based off anecdote, usually when I get some of my pro guys to do it, they usually do them together. But I've never compared. I mean, I don't know. I don't know if it would be any faster with one or the other. I think
Okay.
BPV 157 definitely has the most, I think, promising and the most. I've seen the best results with that personally with
Okay.
my patients. But yeah, so I think it'll be. I think we're still far away from making recommendations because there's just no randomized trials on it.
Okay. But the crazy thing, I think, I kind of skipped over it a little bit just to go back to it, but like you were saying that the guy in the States, I forget his name,
Yeah,
and
Dr. Seuss.
yeah, and you guys both feel that we could probably get better results using the peptides than using HGH. Like I think that a lot of people will probably be surprised to hear that, just
No,
because.
even Tony Galea, who's a pioneer PR, but he wrote a whole book about growth hormone because
Yeah.
there's a reason for that. It's not, there's a lot of science behind it, but the problem is the regulatory bodies are really strict about it. Even in the States now, you can't even advertise that you're offering peptide services, or else the FDA will shut you down. So they're becoming really, really strict about it.
Okay. And I guess it's just because it's something that hasn't had too many trials yet.
Yeah,
So
it's the same issue. It's like the health and fitness space. People get too excited about it before there's enough research, and then everyone just wants to use it. And
yeah.
then it's like, and then the FDA and Health Canada kind of have to step in and be like, okay, chill. Like, but then it kind of ruins it for everyone else because then for us doctors who actually want to use it for our patients in a helpful way, we can't use it anymore because
Yeah. I mean, this is, I guess, another conversation, but I'm sort of in the camp that like if there's like if you're in a position where you're not healing, you're not doing well, there's very limited options available, but
yeah,
there's an option that like may work. Like if I was the patient, I would want to take the option that may work, but I know that there's a lot of people out there that wouldn't, you know and I think that they sort of train doctors to make sure that we won't kind of experiment, I guess you could say, even though it's more or less like, we have no other option. So,
Exactly. Yeah.
this option is the best we have available. Like, why don't we just use the best option?
To me,
That's the way I see
it's always about what's, in medicine we always talk about number needed to treat versus number needed to harm, which is just another way of saying benefits versus potential risk or harm. And
it. Yeah.
so, and that was my whole thing about the orthopedic thing, what we talked about earlier, is like if you're going to take on a surgery that doesn't have very good evidence, for example, like a even a hip replacement or a meniscectomy where they shave your meniscus, those surgeries do not have good evidence. But would you rather try that has limited evidence, that's super invasive and potentially very high risk, versus a PRP injection that maybe it doesn't have that much evidence for a certain condition, but has way less potential for harm? To me, it makes way more sense to try the intervention that has way less risk of harm and it has equivalent amount of evidence. Um, but the government doesn't see it that way for whatever reason. They for like the OHIP covers all these surgeries that don't have great evidence, but they don't cover the plasma injection. So it's just weird.
Yeah, it doesn't make sense. I think we should be able to establish some type of relationship or contract with our patients that, like, hey, like, this isn't, a recommended service by most physicians, or even by, myself even, but, it is an option out there. There is anecdotal evidence, there is preliminary evidence.
Yeah,
Unfortunately, there's not a whole lot of like randomized control trials on whatever it is that, you want to offer that patient, and they should be able to, as an adult, say, okay, I've assessed, everything. I know that I'm in a, fairly desperate position here, so, I'm making the decision that I'm going to take something that may work, knowing that it only that's the best outcome, is that it may work. But I think that adults should be able to make that decision. It's unfortunate that they can't in Canada, and it sounds like in the States it's pretty strict there as well.
yeah, they're just trying to like, yeah, I don't know what it is, but I agree. It's completely. I see those patients all the time. So to me, it's almost like heartbreaking when you see someone who's tried everything and then they're told by their family doctor not to try this other treatment because it's whatever reason the family doctor doesn't even know much about it, but they're just like, oh, there's no evidence for that. Like, just
Yeah.
don't try that. It's like, but they're suffering and they're in pain and they have no other. They've literally exhausted everything. So
Yeah.
why wouldn't you try something?
Yeah, for me it doesn't make any sense, and it's also not very, empathetic towards the
Yeah,
patient. It's like,
that's
hey,
what I
like,
mean. I don't
we
think
don't
it's.
have anything, go home. Like, I don't, I think there's if there's an option, it should be offered to the patient, even if it's not, a strong recommendation from, different medical bodies. I was going to ask, I mean, we only have a couple minutes left, unfortunately, but I was going to, ask you to just a little bit about prehab. I know we got into it a little bit earlier, but, how important is that? Because I know that, I kind of neglected it in my 20s. Now in my 30s, I do a lot more prehab stuff. I use like the So Right tool and stuff like that all the time. And I certainly do, quite a bit of mobility work on my own. But do you feel that that's part of the reason why some people are getting injured maybe earlier than they should be? Is that they're not doing enough, prehab work, not enough stretching, not enough whatever it is to kind of make sure that their body's ready to
Yeah, and again, I
exercise?
I think it's not necessarily the fault of the individual. It's a lot of expertise to say biomechanically, okay, this muscle you need to strengthen, this muscle you need to stretch. Like you won't know that unless you have like some sort of biomechanic background, like, or you're very in tune with your body. So, for example, a common thing is my hips are tight, my hip flexors are tight, right?
Hmm.
That's such a common problem. My hips are tight all the time, but how much you stretch your hips. The problem is we're coming from your spinal instability. So if you don't work on core strengthening and pelvic strengthening, and what starts all that is breathing. So if you don't know how to breathe and your breathing mechanics aren't optimal and you haven't done diaphragmatic breathing and this, there's so much stuff to unpack and unlayer. And like people just don't start from the foundational stuff and then they just expect to do a few stretches and be fine. So it's like, that can only work to a certain point. And I think that's why injury MSK issues are so common. And like, they're just, it's like an epidemic actually. Like it's just like everyone has like back pain and like knee pain. All this stuff is just becoming so commonplace now, and a big part of that is just our evolutionary mismatch, as I always say too, between our environment and our genes, right? We've evolved to
Yeah.
move certain ways, and we're not evolved to sit on our chairs all day and sit in 90 degrees flexion. So I think if you can incorporate like simple things in your house where you're not sitting on like chairs all the time, you're sitting on the floor and just doing simple movement, things like that will make it can add up over time.
Yeah, and last note too before we unfortunately have to close off here is just on the standing versus sitting. I saw this study the other day. It's not a newer study; it's an older one. I just kind of came across it that said that just by standing in the afternoon versus sitting, you're burning like 174 more calories, which is a lot, right? Like if run on the treadmill, it takes a while before you burn off
Yeah,
175 calories, right? So not only will it help with your musculoskeletal health, but it'll also help with your overall metabolic health and with weight loss. So very important, I think, for people to realize that they should be trying to stand whenever they can instead of sitting, and also to make sure you have some type of like prehab program going on, because if you don't, I mean, you basically are going to get injured.
yeah,
You'd be very lucky to not get injured if you're not doing any prehab. So I think that it's almost like a prerequisite, and it's just as important as learning how to lift mechanically sound. I think it's just as important to learn, like as you said, how to breathe, how to do stretches, and to kind of get in tune with your own body. So really good point on that. But yeah, unfortunately, we kind of gotta go here now. So just tell everyone, Adele, where you're working, where they can download or purchase your app, and where they can find you on social media.
well, yeah, just might as well plug it since we just talked about it. If you do need a movement assessment or are worried about getting injured, you can check out Exalt. It's XALT, and we just launched our website. So you can sign up there if you do want to get some movement done from a high quality trainer and have our technology and our years of expertise kind of condensed into this platform. And then in terms of generally just contacting me, I'm in Toronto, Ontario, Canada, and my Instagram is dr.akhan, Khan. And you can don't DM me because I get way too many DMs, but you can email. My email's on there, and I do respond to almost every email. I try to. So anyone can email me if they have questions or anything like that.
Awesome. Well, thanks so much again for coming on. I learned a ton today. I know I'm looking forward to learning more from you. So thanks so much again for coming on, Adele.
Yeah, awesome. Thanks for having me.